Health Town Hall Series. My name is Elise Burr, and I'm the director of the Northern Michigan University Center for Rural Health. We're hosting tonight's program that's been organized in partnership with Dr. Kelly Kam, epidemiologist and assistant professor in the Department of Kinesiology and Integrative Physiology at Michigan Technological University. Tonight's program, we're going to be speaking with experts about Alzheimer's. And I'd like to welcome this evening's guests. Please feel free to log in here. All right, so for tonight's panelists, in no particular order, we have Dr. Roman Politti. He is a neurologist from Marshfield Clinic at the Marquette Center. Welcome, Dr. Politti.
Hello.
We also have Tabitha Guidebeck. Tabitha is a social worker at Norlight Nursing Center. Hi, Tabitha.
Hi, everyone.
And then we have Jack Vanderlucht. He is the Regional Director for Alzheimer Association Michigan chapter right here in Marquette. Hi, Jack.
Hello, thank you for having me.
And our last panelist is Karen Shellberg. She is the Care Consultation Director for the Alzheimer Association Michigan chapter as well. Welcome, Karen.
Thank you.
So I'm happy to say that Kelly Kam is back. She's hijacked us the last couple months, took some time off this summer, but we're happy to have Kelly back. And Kelly's going to share some statistical information with us about Alzheimer's. Thanks, Kelly.
Thanks, Lise. It's good to be back. I enjoy the electricity and all the things that come with modern life again. I first want to start off because for me, this is a field that I really don't know anything about. And so I wanted to start off with a little bit of clarification for anybody who's like me on trying to understand all these different terms. So we often hear in the media and in healthcare, we hear about dementia and trying to understand the difference between dementia and Alzheimer's. So dementia is a general term. So that's the broad term that's talking about symptoms that are showing up because of changes in our brain. And some of these symptoms can be things like loss of memory, difficulty with problem solving, other cognitive functions that affect your daily life. And it also can affect your behavior and your feelings. So with dementia as the broad category, the estimates are that currently in the United States, there's about 7 million adults over 65 who have dementia. Now, Alzheimer's, and our panelists are the experts, so please, if I'm incorrect on any of this, I appreciate being corrected on this. So Alzheimer's is a form of dementia. So it's the most common type of dementia, and about 60 to 80% of these dementia cases are Alzheimer's. It is the 6th leading cause of death in the United States in adults, and if we limit that to adults over 65, it's the 5th leading cause of death. So a very common problem, which is why we have it as a topic tonight. It is likely probably underreported. There is data that shows that it's Alzheimer's tends to be unreported on our death certificates as a cause of death. And then from a statistical point of view, there's a really interesting phenomenon that because our baby boomer generation is becoming older, and that's such a large number of people, that are the proportion of people over 65 with dementia is dropping. But because there's so many people moving into that over 65 age group, then the raw numbers, those actual numbers of people with dementia is rising, and with Alzheimer's is rising. So estimates for 2020 that right now we've got about 5.8 million adults living with Alzheimer's. That number is expected to triple to 14 million adults by 2060. Risk does increase with age. And so the estimates that I found that the number of people living with Alzheimer's disease doubles every 5 years beyond age 65. And if you get up to our upper age groups, I believe over 85, it's about 1 in 3 adults have Alzheimer's. There's quite a few risk factors. I'll leave that to Dr. Politti to talk about. But one of the things that has been kind of in the literature, in the scientific literature, has been kind of questionable is there is an association between cardiovascular disease and Alzheimer's disease. And as in the scientific literature, that seems like to be a little bit of a question if it's because of shared risk factors like lifestyle factors, smoking, poor diet, lack of physical activity, all of those things that affect so many of our health conditions, or is there something that in addition to those common risk factors, that cardiovascular disease in and of itself is actually a risk factor for Alzheimer's disease. We do see race differences. So Latinos have a 1.5 times increased risk of Alzheimer's compared to white adults at the same age, and Black individuals have a double the risk of Alzheimer's compared to, again, whites at the same age. And again, there's a lot of work being done right now trying to figure out why those racial disparities are there. It is an extremely costly disease. So from a public health perspective, as well as an individual family dealing with issues of this, it's very costly. The costs estimated of treating in 2010, so this is quite a little bit of time ago, was between $159 to $250 billion, and projected to increase to as much as $500 billion by 2040. Now, those were looking at dementia costs, not specifically Alzheimer's, but again, Alzheimer's being the primary disease within that dementia group. The reason that those estimates are pretty wide is because it's really hard to figure out how we estimate the informal care costs. So many of the people who are helping care, and I think Karen will speak about this, who are caring for these people being cared for in the home, and how do we measure that? So that's why we get these really big ranges. And a huge cost to Medicare. So of that 159 to 215 billion, Medicare was covering 11 billion of that. And when we look at it for a per person cost, that's about $40,000 to $55,000 per person per year are the costs that we're looking at that. So with those estimates in mind, I would like to introduce Dr. Paletti to speak about his perspective as a provider. So welcome, Dr. Paletti, and take it away.
Hello. Well, all right. Yeah, certainly Alzheimer's is even still under-recognized. A lot of people still, when it's early, when symptoms are very mild, people are attributing it to just aging. Oh, mom's just getting a little slower. But certainly something that we'd like to get on top of in terms of trying to get people into the system. If they are having symptoms, get them evaluated, get them diagnosed, hopefully. One of the things as a provider that's most important for me is having a family member or a good friend come with the person to their visit, because if they do have dementia starting, they probably are not going to give me as fully accurate a history as a family member may. And the person themselves may not have full insight into their degree of impairment. So it's always helpful to have that extra assessment, that extra history available. We're definitely going to want to know, duration of symptoms. Is this something that just started within the last few months? Has this been something that's been creeping up for years by the time they're coming in? Because it puts us in different categories of conditions we're worried about. And then we're really going to be focusing on the history. How did it present? What are the symptoms? What are the associated problems? To what degree is it impairing their functioning? And that may impact, if they're a pre-dementia diagnosis, something called mild cognitive impairment, or whether this has crossed that line and now it's getting in the way, and we start using terms like Alzheimer's dementia, Lewy body dementia, frontotemporal dementia, things like that. You talked a little bit about risk factors. Certainly, the by far the biggest risk factor is going to be aging. Now, each decade of life as people get older, the risk factor goes up significantly. There's a genetic component to it. The details of that are still a little murky in terms of putting it in clinical practice, but certainly families where it tends to cluster, family members are going to be at somewhat higher risk. But even without a family history, it's just fairly common with aging. And really the risk factors that people have some degree of control over is cardiovascular risk factors that we're controlling for high blood pressure, diabetes, cholesterol, weight, sleep apnea, all those things that we might be able to intervene early, but they probably have a cumulative effect of damage to the brain over time, leading to the symptoms of dementia with having, forgetfulness, trouble with their functioning in the home, really that loss of independence and really needing more direction as they go. In terms of in the clinic, when we see somebody, in addition to getting a full thorough history, ideally getting notes from their primary care provider, if they're coming in to see a specialist, we're going to do some sort of cognitive testing in the primary care office and maybe even in the neurology office We might do a simple screening tool, something called the mini mental state exam. There's some variants of that. These are fairly quick tests, really shouldn't take more than 3, 4, 5 minutes if somebody's doing fairly well, and really just get an idea of whether they're really functioning highly or whether they're struggling even on a screening test, about what other testing we might do. Sometimes we actually in our clinic use a program on an iPad. Takes about 10 or 15 minutes. It's a little bit more in depth, gives us a little more understanding of what degree they're impaired. We might send them to an occupational therapist to do some extra testing. Person might spend an hour, maybe 2 hours with them. Or is this somebody where it's really a more complicated presentation? Maybe they're presenting at a suspiciously early age, and we might send them to the neuropsychologist, PhD psychologist, that's really going to spend several hours with them and really get an in-depth, thorough evaluation. Typically, we're going to take a picture of the brain, CAT scan picture, an MRI picture, really not so much to show Alzheimer's, but to help exclude things that may mimic it, make sure we're not missing strokes, make sure we're not missing bleeding on the brain, make sure the person doesn't have extra fluid in the brain, hydrocephalus. Those are some conditions we would treat very differently. And then there's probably going to be some blood tests, maybe urine tests that we're going to do. Again, not so much to prove Alzheimer's, but to exclude things that would mimic it, medical conditions we would treat differently. So I'd say those are probably the evaluation parts. In terms of treatment, I'll just touch quickly on, for the bulk of my career, the treatments we've had available for Alzheimer's have been very modest in their benefit. They're what we call symptomatic treatment. They help a little bit with thinking, they help a little bit with forgetfulness, but they're not in any way a cure, and they don't actually slow down the disease. So these are the drugs that we've had for years, and we do use them because they've been the state of the art. Really now within the last year, we have some new options, which are what we call disease modifying therapy. And this is what we've been looking for years. And this is new treatment and really changes a little bit of our calculus on how aggressively to get somebody in to be evaluated, really showing the first signs of memory loss, where these drugs are most effective at the very earliest signs, even that pre-Alzheimer's stage, where they might have that mild cognitive impairment stage. And then we can intervene with medication that actually attacks the bad protein in the brain that's causing a lot of the damage and inflammation. And if we can intervene at that point, we can slow it down and hopefully give the person a lot more quality of life for a lot longer. It's not a long-term cure, but it definitely can help. This is the first real chance we've had to slow it down. So that's been very promising, and really looking forward to getting more aggressive with that type of treatment.
Dr. Politi, I wanted to ask you, in the years that you've been treating this, have you seen a change in the types of medications or the treatments that are being provided to patients?
I mean, really, the drugs we have are fairly modest. The main category that came out at first was acetylcholinesterase inhibitors. These are the ones like Aricept or the generic donepezil, the Exelon, Razidine medications, rivastigmine. Those drugs all work on the acetylcholine neurotransmitter in the brain. Again, they help boost thinking and memory a little bit, but very modest benefit. The other drug is a drug called Namenda or Memantine, or sometimes there's a combination pill called Namzaric that's out there. And it works on a different neurotransmitter, glutamate in the brain. And they have some synergistic benefit when you treat them both. But again, these are modest benefit and really not slowing down the disease, the injury in the brain.
And I wanted to ask you, we've heard a lot over the years to say, oh, do crossword puzzles, that'll keep you, fresh in the head. And, are there things that people can do to actually prevent getting Alzheimer's?
Not so much prevent, and I think there's been a little mixed messaging on some of those things. I think what I've understood is really a lot of the interventions boil down to maintaining social interactions, whether it's with family, friends, getting out. People who come more socially withdrawn have a lot more trouble, exacerbates the symptoms they would have. So if you enjoy doing crossword puzzles, by all means, continue doing that if you enjoy it. But I think some people feel obliged to do crossword puzzles, and I don't think the evidence is that strong for those sort of games.
what kind of advice? My hope is that there will be people who are either listening on the radio tonight or joining us on Zoom or watching this recording afterwards. And what would be, I guess, good information to share with individuals who may not have been touched by Alzheimer's yet? What kind of information would you want to share with individuals who might have this coming at some point in their life, whether it's with a friend or a family, loved one? What kind of advice would you have for them when it comes to the medical aspect to this?
I think from the medical aspect of it, I think we approach a lot of medical conditions as if it's a short term. We just have to get over the hump. You need a surgery, you recover from surgery. You have an injury, you recover from an injury. Where I think it's a little different mindset here of this is going to continue. Even with full treatment, it's going to get worse over time, even with full treatment. And I think getting people to understand it's not a day-to-day, week-to-week, month-to-month, but this is now a year-to-year condition that we're going to have to deal with and be realistic about. What are their limitations in terms of driving, in terms of handling their own financial affairs, and making sure we kind of get ahead of those things before there's a crisis, before there's a problem.
So I have a quick question for you, Dr. Paletti. As you mentioned that you are talking with the primary care provider for these patients. So what is the interaction? Do people continue to see their primary care? Are they asked, are the primary care providers screening people as it's so common and getting to be so common among older adults? Are they regularly getting screened and getting to you, or how does that
It's
how does that
still
work?
quite variable. It's very different. Physicians have a different approach. Kind of an older school medical approach to this is because we didn't have a cure or a significant intervention, actually labeling Alzheimer's was not as high of a medical priority for some of the older providers. I think that mindset is changing now, especially as we see there are ways we can help intervene medically and socially earlier. I think it makes the whole process easier on the family and the patient. But again, that's a bit of a cultural switch, which is happening within medicine. And I think we're going to see in the next couple of years, as word gets out that we actually have intervention to slow down the disease and catch it early. Somebody a primary care doc that might not have screened as aggressively is now going to see, boy, my patients in their 60s that I might have looked the other way when they had some cognitive complaints. Now I'm actually going to do a mini mental state testing, or I'm going to do some other intervention, something called the mini cog, very straightforward, very brief testing for a couple minutes, even just to get a good baseline and see if they need to be sent on for further evaluation. But I think we're going to see that that's more aggressive. Some of it's also going to be driven by patients and their families. As word gets out, they're going to insist that mom or dad be screened and get appropriate care.
So
and the Alzheimer's Association has been pushing it too. Sorry.
No, that's fine. When Kelly and I were trying to come up with questions, just to make sure that we were trying to read minds of our listeners a little bit, one of the things that we wanted to ask you, and I understand this is just opinion-wise, this isn't a fact. So, but we wanted to know from you, if you think that Alzheimer's may be underdiagnosed in general, just because of the number of tests that have to be run to actually rule things out. Do you think that prevents people or makes people hesitant about going through that process?
I think it does. I also think certain, minority communities I know are definitely underdiagnosed. I think there's a little bit of a stigma still in certain communities that we treat our own, we take care of our family member, and maybe not label things with a medical diagnosis that old people get dementia, whether we call it Alzheimer's or not. I think, again, it's a cultural switch because we don't have a cure for it. How much to label it if mom's now living with, daughter and family and getting by, and they don't need to drive and they don't need to handle their finances. It's not as much of a burden because they're already taking care of all that. But I think it's definitely underdiagnosed in terms of, labeled in the medical chart. Many, unfortunately, people in nursing home settings, again, they may not be as aggressively evaluated in that setting because they don't need to handle as much on their own day to day.
Right. Very good. Well, I want to thank you about being a guest today. I know that this is something that you're pretty passionate about.
Yeah.
And I really appreciate you taking time to be on this program tonight. So thank you. We really wanted to start off with Dr. Politi to set the table on this for tonight's discussion, because we have some great expert panelists who are going to talk about, okay, so you're diagnosed, now what? What comes next? For listeners who are just joining us, this is the UP Community Health Town Hall program, and tonight's episode is Alzheimer's. We have some wonderful guest panelists this evening who are joining us. And next up, I'd like to introduce Tabitha Guidebeck. She is a social worker from Norlight Nursing Center, and she's going to talk a little bit about the services that are available to people who have been diagnosed with Alzheimer's, as well as their family members. A lot of people focus on the individual themselves, but as we know, it's not uncommon to have a care system, and to have a number of people that take care of us up here. So Tabitha, welcome to the program.
Thank you. Absolutely. Thank you, Elise. So like she said, once someone does get a diagnosis of Alzheimer's disease, it's like, now what am I going to do? Where am I going to reach out to? Me personally, of course, I'm know a lot about the Marquette community, or in general, the UP. So I wanted to just touch base on some local organizations and then maybe some further out organizations in general to help someone with Alzheimer's, and hopefully that people can understand the disease a little bit better. The first I wanted to talk about, it's through the triad of Marquette County, and it's a life tracker. So this is like a bracelet that someone would use if they were like later stages of their Alzheimer's diagnosis, and maybe they wandered or were not safe at home by themselves, maybe had a caregiver. So they would wear the tracker, and it's just a safety precaution for if an individual were to start wandering. I also wanted to talk about a list of community resources. I always, when I talk to my individuals, the family members and Alzheimer's patients, I always tell them, when in doubt, call 211, call UPCAP, it's called the Upper Peninsula Commission on Aging. It has a plethora of resources, services, support groups for caregivers and for Alzheimer's individuals, so that if they don't know where to go next, maybe they're questioning, is this individual safe at home? Do they have enough resources? They can reach out to UPCAP. Another one, of course, I won't get into it much because I know we have two professionals from the Alzheimer's Association Marquette chapter, but that's another resource that you can reach out for information, for resources. Just in general, a very good one. I won't go into much detail, but reaching out to local senior centers, the Retired Senior Volunteer Program, CAM. These are services that would help someone more so keep their independence and stay in the community. Maybe they have Alzheimer's, and it's like everyone thinks that, okay, now it's time for a nursing home. And that's not always the case. We understand that only 1 in 10 individuals on average age over 65 will end up in a nursing home. So what happens to the other 9 out of 10 seniors or younger that get diagnosed with Alzheimer's disease? So these services are really in place to help them stay safe as possible and stay independent as possible and know what resources are available. Through CAM, it's Meals on Wheels. They can deliver home delivered meals to seniors if maybe with their progression of their Alzheimer's disease, they're losing the ability to cook. Maybe they don't remember how to use the stove, or maybe it's just not safe anymore. So this is a good community resource. Reaching out to churches, you don't have to be religious to reach out to local churches. A lot of them have caseworkers or just community support that is able to support these individuals. And then, of course, you can always reach out to local assisted living facilities or nursing homes to talk to social workers or caseworkers about even the process of getting into a nursing home, what it takes. It's just a good idea. And then also looking online at resources. It's of course important to make sure you're looking at accredited resources. You don't want to be looking at things that are going to give you false information. So it's important to look at things like, of course, the Alzheimer's Association, alzheimers.gov, Elder Care Locator, the National Institute on Aging, things that are going to be credible, give you some more information on maybe the progression of Alzheimer's. But when in doubt, it's always best to reach out to your primary care physician. And then I always tell people, don't isolate. You have a huge community behind you with ample amount of resources. We don't want to see you or your loved one isolate and not know that you have a community behind you. And then when in doubt, maybe go to a local seminar. I know we just had one a few weeks ago with resources. And then last for this section, it's important if you get diagnosed with Alzheimer's from your physician or wherever it comes from, maybe it might be a good idea if not already in place to get your affairs in order. I see this a lot in the nursing home where they wait too long, wait until an emergency happens or a disaster happens where maybe they're no longer safe at home and they have no other option but to go to a nursing home or move in with a family member. But if you have these difficult talks with your loved one, then you can be better prepared and make sure that your wishes are being better known when something does happen. Maybe getting a living will in place, maybe just looking at local nursing homes or assisted living facilities or adult foster care homes, just to see what's out there, just so if you ever do need it, and you're a little bit more familiar with what the setting is about.
Thanks, Tabitha. You mentioned that people can be cared for in their home, and that can be a pretty stressful thing on that individual who's the caregiver. So as a social worker, are you working with the families as well as the patient to support the family and what the caregivers need?
Absolutely. As my role as a social worker at Neurolight Nursing Center, I'm of course there for the residents. A lot of them are in different stages of their progression, and of course everyone's different. So I'm always there to lend a helping hand for the individuals. But as you know, would or can imagine, being a caregiver or a loved one of someone with Alzheimer's, especially as their disease progresses, can be significant. So I do a lot of just support, open listening, referring them to other resources if possible, helping them find a local support group or a virtual support group, just to know that they're not alone and that there is support available.
Great. And as I was looking up information, I was shocked as to the cost of everything. So can you speak a little bit about insurance coverage and what might or might not be covered, particular for Medicare patients, with it being more common in older adults?
Absolutely. I didn't even realize until I started working in a nursing home. Of course, the cost of things is crazy, but a lot of people don't realize that many, I can't speak for all, but most assisted livings, as they are an amazing option, they are private pay, they aren't covered by insurance. So many people don't have any other option, either to stay in home or apply for Medicaid and get into a nursing home. Assisted living facilities are an amazing option. Many of them even have memory care units available. For the staff is specialized and trained to work with Alzheimer's individuals or people with dementia. It just depends on, I don't know the exact cost of things, of course, but I do know that many assisted living facilities are out of pocket. So if someone is unable to afford that, then they can look at other options like in-home care, which sometimes is covered under insurance, or trying to go to a nursing home, which either can be private pay or covered under insurance.
Great. And then, go ahead, Elise.
No, you go.
Well,
You're good.
The last question I had was that trying to think about it's difficult enough as we have any conversation with the older adults in our family, whether it's our parents or grandparents. How is there any magic question or anything that can help someone understand that really this is the time where we need to get more help for this family member or friend, particularly whether it's a family member or where we are. You guys have urban areas in Marquette, but up here in Houghton, we have a huge number of our older adults that live alone. And so thinking about what might a neighbor notice that really indicates that they need some additional services and some help.
Absolutely. I always tell people, of course, your loved one the best. If you see things out of the normal, maybe they're forgetting to take their medications, they are going to the store and forgetting how to go home, or it could be as little as just being more forgetful is more than usual. When in doubt, I highly encourage everyone to talk to your primary doctor. They have a plethora of resources and of course warning signs of someone who might have Alzheimer's or need to be diagnosed with Alzheimer's disease. It might be a good time to look at getting someone more help if they are not able to live independently anymore. They need more help than that can be provided in the community. They have a caregiver that maybe not be able to help assist them anymore. Maybe their caregiver is burnt out or sick themselves and is unable to care for that individual. It's just it's important that if they're unable to function daily, they need more resources that are available than in the community. Then it might be time to kind of have that difficult but important conversation with your loved one, or the individual with Alzheimer's having it with their loved ones about maybe it's time to look at different options or reaching out for better resources.
Thanks, Tabitha. It can be a challenging topic, when it hits close to home. I know it's touched our family, and when you've never gone through it before, it's a little daunting at first because you're not sure who to reach out to or who else understands what you're going through. And I really think people can learn a lot from tonight's program and feel like they have some kind of support system out there, to really work with us. So thank you for spending some time with us tonight.
Absolutely. Thank you.
Yeah. Our next guest is Jack Vanderlucht. He's the Regional Director for Alzheimer's Association of the Michigan chapter, and he is right here in Marquette, Michigan. So Jack, thanks for joining us tonight.
Thanks for having me, Elise. I would like to, talk to the basics of what dementia is, and then we talked briefly about risks associated with Alzheimer's disease, but I'm going to go over some ways that we can reduce our risk of getting Alzheimer's disease in the future. So Dr. Roman mentioned this earlier, but dementia is a group of symptoms associated with a decline in memory, cognitive, and reasoning skills. There are many causes of how someone could get dementia, with Alzheimer's being the most common. And we like to stress at the association that dementia is not a normal part of aging. I know I've encountered people who just kind of assume that as we get older, these type of things starts happening to us, and that is absolutely not true. It's not a normal part of aging. So we also learned tonight that age is definitely the greatest risk. So when we turn age 65 and every 5 years after that, our risk of getting Alzheimer's disease doubles. And then after, I believe, 80 or 85, 1 in 3 adults have Alzheimer's disease. But there are ways that we can make changes now. It's never too late or too early to make good lifestyle changes that can reduce our risk of Alzheimer's disease. So one of those things that we can do is, if we are a smoker, we can stop smoking. There's some research coming out that suggests that people that have cardiovascular disease are at a heightened risk of getting Alzheimer's and other types of dementia. So we can adopt better eating habits. So there's 2 types of diets that the association recommends. One of them being the DASH diet, which stands for Dietary Approaches to Stop Hypertension. That diet includes lots of vegetables, fruits, whole grains, fat-free or low-free dairy products, fish, poultry, nuts and seeds, and vegetable oils. I personally love avocado oil. Olive oil is great. I've heard good things about peanut oil, but that's what I can speak to. Then I think a lot of people have heard about the Mediterranean diet. So that diet comes from the cultural eating habits of peoples that inhabit the areas around the Mediterranean Sea. That diet has been proven to decrease cardiovascular risk of cardiovascular disease. And that diet includes a lot of vegetables, fruits, beans, lentils, and nuts. Lots of lean meats. We live up here in the UP, and I know lots of people love hunting up here. And venison is indeed a lean meat. It's very, very wonderfully delicious if you cook it correctly. And we also have wonderful access to Lake Superior, where we can get fresh whitefish, which is another great lean meat that you can eat. Things like that with omega-3 fatty acids that are found in fish. I think Dr. Roman also mentioned this earlier, but physical exercise is absolutely wonderful for your heart and for your brain. And some scientists are suggesting that there's one thing that you can do right now to help reduce your risk of getting Alzheimer's disease. It's to go biking or get outside, do some type of physical exercise, even if it's for 15 minutes a day. Any type of amount that you can do that is obviously safe and relevant for you is going to have lasting impacts on your life. So, obviously we live in the UP. We have summer for 3 months out of the year. So during those 3 months, you definitely want to walk around your neighborhood. If you have a friend, if you have a dog, take them for a walk, do things like that. Maybe walk along the beach or in the woods. We have lots of wonderful, beautiful places up here in the UP. In the wintertime, I know it can be a little bit more difficult to get outside, but snowshoeing could be a wonderful option. I know there's gyms and places that we can walk inside. If you live near one of our many colleges up in the UP, they definitely have indoor walking tracks where people can go and walk, things like that. I think, again, Dr. Roman probably mentioned this, but maintaining social connections is a very important aspect of reducing your risk of Alzheimer's disease. So we have so many options especially right now, we're on a webinar. There's many options that you can use to maintain contact with your friends and family. If it's through a Zoom call, if it's through FaceTime, you could call them. There's senior centers you can go to for those type of group settings. There's coffee shops. You could just, have a friend over for tea or cookies or whatever you'd like. And then obviously we want to reduce our risk of falling and head trauma as we get older. Some ways you can do that is obviously wearing a helmet while we ride a bike, or maybe wearing a helmet if you're cross-country skiing or other type of winter sports that we do up here in the UP. And then something that some people forget to do is clutter-proof your home. So during spring cleaning or fall cleaning or whenever you like to clean, make sure to go around your house, pick up any loose wires, any type of extension cords that might be laying about that could cause you to trip and then hit your head. Also, minimizing clutter in your rooms, organizing things, anything like that would be able to reduce your risk of falls. Obviously, we want to consult our caregivers before making any type of major lifestyle choices. If you have allergies, obviously don't get on a diet where you can't eat the foods. And then if you are thinking about increasing your physical activity levels, we definitely want to consult our physicians and caregivers before we do so to make sure we're doing it in a healthy and also, again, relevant manner. If you can figure out a way that you can stay physically active, but you also like to enjoy the things that you're doing, you're more likely to follow through on those goals and accomplish those things. So what are some what are some programs and things that we can get up here in the UP? Well, I am the regional director for the 15 counties up here in the UP. You can contact me directly. My personal office number is 906-373-3107. So in the UP, we have a lot of education programs that are coming out around the 15 counties. Those education programs range in a wide variety from just what an introduction to what Alzheimer's and dementia are, all the way up to financial planning for caregivers. We have specific education programs for the different stages of the Alzheimer's spectrum. We have we have a program that's dedicated on how to reduce your risk of getting Alzheimer's disease. I just covered the basics in the earlier section I just talked about, but we kind of delve really in depth on those topics in that education program. We also have support groups up here in the UP. There's definitely more coming. Currently, we only have 2. So there's one in Iron Mountain, and then there's one in Sault Ste. Marie. But one is coming very soon to the Calumet area. I'm very excited about that. And then we're working on getting one in Marquette. Hopefully, we're going to have, in the future, I would love to have a support group in every county, if not multiple support groups. I don't want to be redundant with my wonderful coworker, but we do have a hotline, and that hotline number is the 800-272-3900. That is a wonderful resource that you can call 24/7. You'll be in contact with somebody from the state of Michigan. They can help you at any hour of the day to get to the support and help that you need immediately. You also can go to alz.org. So that's our online website. There's thousands and thousands of research articles and wonderful data that you can read about and also get in contact with others. We have our community resource finder up here and everywhere because up here in the UP, it can be difficult figuring out where we need to go to find specific resources. So if you go to our website and you find our community resource finder, you will be able to type in your zip code and it will tell you what resources are near you. And then, of course, we have the Walk to End Alzheimer's this month. Next month. Sorry, it's the 31st. Next month, September 23rd. Is the Walk to End Alzheimer's, known as the world's biggest support group. We're going to have a lot of people downtown in the Lower Harbor Park in Marquette, Michigan. It's going to be a great time. There's going to be music. There's going to be food. We're going to walk. There's going to be a lot of people that are there to support each other and support their loved ones that have Alzheimer's disease. And we'd love to see anybody who's interested come.
Thank you, Jack. That's a lot of information, to really share. Can you talk a little bit about any other future plans? You talked about, did you say support groups?
Yes.
In some of those areas, is there anything else that's kind of on the horizon?
Well, I'm looking for people who are really passionate and dedicated to helping others with Alzheimer's disease to be a volunteer with me. There's only one of me up here, and I would love it if we had volunteers in the different counties of the UP that can put on these support groups, that can put on these education programs and really get the word out there. Because a lot of the times it really starts with our loved ones and our community to identify those that may be struggling with the disease in the early stages to get them the support and the diagnosis that they need.
You've covered a lot of information, and I know that this is something that you've been excited about, this show coming up and being able to share your information. And with Kelly being at Michigan Tech and me being at Northern, our hope is that we're able to engage more the university students, staff, faculty, and supporting some of these initiatives throughout the Upper Peninsula. And we're fortunate to have a decent relationship with all of our universities up here. So I think it would be great to really try to promote what you're doing and take it to that regional level and really, have a voice a little bit stronger right now to support Alzheimer's and what's happening. So thank you for everything that you do, Jack.
Thank you, Elise.
If you're just joining our show, this is the UP Community Health Town Hall program. And tonight's topic is Alzheimer's. We have one guest panelist who's left, but before we get to you, Karen, I do want to mention that I had also talked to people in law enforcement about being a potential guest on this evening's program, and they were unavailable to be able to join us, but they sent me some tidbit of information that I just want to share with people. I talked a little bit about what happens when someone wanders away from home, or if somebody wanders away from their living place where they are. And the local sheriff had shared to stress the importance of calling 911 as soon as the caregiver discovers that a patient has gone missing, and that timing is very important, that is of essence. To urge the caregivers to also enroll in Smart 911. which can then include the Alzheimer diagnosis. So that was something I had not been familiar with. So I wanted to make sure we shared that with everybody. It also, he also had mentioned that he would urge caregivers to enroll in the Life Tracker, which will also become a part of Smart 911. In particular, this individual's in Marquette County. This is so that the Marquette County Sheriff's Office can have search and rescue notified as well. So I would anticipate some of that is common throughout the region. But just wanted to bring that up because that was one aspect that we didn't have really covered for tonight through the guest panelists. And I would like to introduce Karen Shellberg. She's the Care Consultation Director for the Alzheimer Association of Michigan chapter, and working with Jack from downstate. Karen is joining us tonight. So thank you, Karen.
Great. Thank you for having me. So I am going to kind of touch on some common behaviors and communication tips and things that might help caregivers. But before, I just wanted to piggyback off of Jack as well, as he was talking about our programs and services. We also, just to keep this in mind, we do have, as I talk about some of these behaviors and communication, we do have a care consultation program as well. We can meet people in the UP either by telephone or virtually by Zoom or Google Meet. And we have social workers who can work with family members, complete an assessment, so gather information about the caregiver or the person living with dementia. We can help put together a care plan with different goals and action steps. So maybe it's addressing some challenging behaviors, helping the caregiver increase self-care, and then we can meet with them for follow-up sessions. And this is a free program as well. So I'm just going to put the plug in for our 1-800 number again, 1-800-272-3900. That's our 24/7 helpline number. So if you hear of any resources that you're interested in tonight, I would encourage you to call that number, and we can help connect you with whatever it is that you need. So thinking about, I think Dr. Politi kind of referred to earlier, as the disease progresses and it can become more challenging for caregivers to care for their loved one and very stressful. And there are behavioral and psychiatric symptoms that can often be seen in people with Alzheimer's disease and other dementia as the disease progresses. And these, behaviors that can occur, you can kind of think of a behavior. I like to think of a behavior as more of a form of nonverbal communication. So usually when someone has a behavior, they're expressing a feeling, they're expressing an unmet need, some sort of intention that maybe because the disease has impacted their ability to verbalize what it is they need, they're quote unquote acting out, or there's some sort of behavior that's trying to express that need. There can be a lot of different causes of behavioral symptoms in dementia. Some of these could be underlying medical conditions or infections. It could be medications the person's taking. It could be changes in the environment, changes in caregiver. So I'll kind of touch on a little bit of that as well. But it is really important. We often tell family members that if they do see a sudden change, if their person doesn't experience any behaviors, and then one day they wake up and they're experiencing delusions, hallucinations, it's a very sudden change, it's really important to make an appointment with the medical provider to make sure there isn't some underlying infection or something that's going on that could be a cause of that and that could be treated. And then, a lot of behaviors, which again, as the disease progresses, can be one of the most stressful pieces for caregivers to kind of handle, especially when they're caring for someone in the home. And communication and changing communication techniques can be super helpful. So just in the, with timing tonight, I'm going to just touch on a couple of kind of common behaviors. Again, not everybody with dementia will experience all of these behaviors or any of these behaviors, but these are just some common ones that often kind of lead to a call to our helpline, or, we want to talk to a social worker because we're not sure how to handle this. So if you've heard of delusions and hallucinations, so those are two kind of common behaviors. Delusions are a false belief or idea. So it is a thought that, for example, delusions of theft. So somebody's stealing from me, someone's stealing my purse, someone's stealing my money. Delusions of infidelity, their spouse or love, their spouse is cheating on them. Those are some kind of common delusions. And those suspicious delusions can also be referred to as paranoia. Hallucinations are a false perception. So the delusions are the false idea or belief. Hallucinations, a false perception of objects or events. So usually sensory in nature, seeing things that aren't there, hearing voices that aren't there. And it's really, both with delusions and hallucinations, it's really important to assess whether or not the delusion or hallucination is upsetting to the person living with dementia. Sometimes it's almost more upsetting to the caregiver than it is to the person experiencing it. Not always the case, but maybe the person with dementia is, seeing children playing in their yard out front, and they love watching these children play. And it's very, it's not upsetting to them. And the caregiver might, try to correct them. And that is what you don't want to do, is to correct or to argue. You want to kind of enter their reality. And so it's really important to figure out, okay, is this upsetting to them? Is this something that could be of danger to them? Trying not to use reason and logic, throwing reason and logic out the window. So you almost have to, as the caregiver, enter into that person's reality. Know that, if they see something and they are convinced that that is there, or they have a belief that they are convinced is real, there is no amount of reasoning or logic that is going to convince them otherwise. So I've often had people might not recognize their spouse who they've been married to for 50 years. And I've talked with caregivers who have said, I showed them our wedding picture. I showed them our marriage certificate. I showed them, and they still don't believe it. And it can be extremely distressing for the caregiver. And so it's very difficult, especially when it's personal, that, they don't recognize their spouse, to kind of enter in and to be okay with, oh, your husband's going to be back in a little bit, and entering into that reality. But by doing that, it can help to kind of ease some of the distress that those delusions and hallucinations might cause. So even thinking about, sometimes people might look in the mirror and they don't recognize themselves and they think it's someone else. So modifying the environment, taking down the mirrors or covering them up. If they think something's being stolen, buying duplicates of that item so you can easily replace it if it is something that's easily replaceable. So kind of figuring out how the environment can be modified can be really helpful as well. Wandering was touched on a little bit. That can be another very common behavior. There can be many reasons for wandering. 6 in 10 people with dementia will wander at some point. A lot of people, again, they have delusions, hallucinations. They believe they still have to go to work in the morning. They believe they need to get their children on the bus to go to school. They believe maybe that their house isn't actually their house and they need to go back to wherever their childhood home was. And so in addition to Life Tracker and some of the resources that were mentioned, just increasing supervision, putting door alarms, wander guards, keeping a consistent routine, removing keys if they're threatening to take the car, those can all be helpful techniques to use. And then aggression and anger can also be another behavior, especially physical aggression can be really challenging because we want to make sure the person with dementia as well as the caregiver is safe. And so, again, looking for unmet physical needs with that. So is the person becoming aggressive or angry because maybe they're in pain and they can't express that verbally? Maybe they're hungry, they're tired, they're cold or hot. You're trying to bathe them, dress them, and they're uncomfortable with that because it's a very personal thing. And so it might come out in some sort of behavior. Looking at, when thinking about tasks like bathing and like taking a bath, for example, which can sometimes be a really big challenge, thinking about time of day. Is there a time of day where the person functions, is in better spirits? Is the morning better for them? Great. Let's do baths in the morning instead of baths at night. And then really looking at communication from the caregiver. So, asking too many questions at once, giving too many tasks, okay, you need to go do this, this, and this. The person might not be able to process all of that. So really simplifying, breaking things down into simpler parts. And then also thinking about our nonverbal communication. If a caregiver is stressed, if it is in their tone of voice, if it is in their body language, the person will pick up on that. And so if they are becoming stressed, if they can recognize that and take a break and take a step back and be able to kind of come back to whatever task it is later, reducing distractions. So all of these little tips and techniques, these are things we can go over. I know are gone over in education programs, support groups, our care consultation programs, but a lot of it is, it's almost reteaching the caregiver how to communicate, because you're used to communicating with this person in one way, using reason and logic. And then when you bring in Alzheimer's disease, everything just kind of flips and you have to look at that again. So I know we're getting close on time. So just a couple more. I want to talk about the 3 R's of communication. So I often, I mentioned not correcting, not arguing. And so I love the 3 R's of communication. So the 3 R's are right, reassure, and redirect. And so the first one, right, this is often the hardest. The person with dementia is always right. So they see, they believe they need to go to work, then you enter their reality and they need to go to work or they need to go home. They believe or they see things that aren't there, you enter into that reality. The second R is to reassure. So that's really looking at the emotion behind what they're saying. Oftentimes, again, a person says they want to go home, they want to go home. They may be feeling anxious, unsafe, kind of unsettled, and home is a very comforting place. So looking at, okay, what are they saying? What could the emotions behind that mean? And reassuring them that they're safe, they're taken care of. I understand you want to go home. We're going to go home tomorrow, but I've arranged for us to stay here tonight and you're going to be safe here with me. And then the third R is redirect. Why don't we go have a snack and watch a movie before we go to bed? And so redirecting, finding those favorite activities in a toolbox, but the right, reassure, redirect can be a really helpful kind of tip and technique to keep in your back pocket when communicating with someone with dementia. Yes, I'm trying to think. I think the last thing, which is sometimes is very difficult as well, as I talked about, oftentimes caregivers are spouses, they're adult children, but really trying not to take things personally and what the person with dementia says, remembering that the disease is affecting their brain and is causing these changes in communication. And they often take it out on that primary caregiver, the person who's closest. And so to be able to kind of step back and to, take a break, walk away, come back and remind yourself that this isn't personal. So that's my communication and behaviors in a nutshell.
No, that's great. I want to thank you. That was great information. I know when I was helping somebody who had recently been diagnosed, one of the quick fixes we did initially was, okay, you don't need to balance your checkbook anymore. I'm going to give you a food card to take to the grocery store and you don't have to balance anything. Just bring your card and bring the receipt home. And I mean, she, all of a sudden you could just see the relief on her face about, you mean I don't have to do that anymore? I mean, some of just those everyday things that were really stressing her out and giving her anxiety. We found ways to relieve that. And of course, sometimes that's only temporary, but to be able to work through that and pivot, I think is really important as a caregiver.
Yeah. And even, if there's certain tasks that the person always did, like balancing the checkbook or something like that, sitting down with the person and let's do this together. Let's fill your pillbox together. Let's, why don't we go grocery shopping together? Can you show me how you kind of manage this and write out the bills? Give the person still a sense of purpose and a feeling like they're helping and they're contributing. And I think if you can, do things together, not necessarily just take it away, but sit and, I'm going to balance my checkbook. Let's do yours too. Or I'm going to write out the checks and have you sign it. And, we're going to put it in the envelope and you can put the stamp on it. Just breaking things down, making it simpler, but still giving the person that ability to do what they can in a safe way.
Thank you, Karen. I'd like to thank all of our guests tonight, Dr. Roman Politi, Tabitha Guidebeck, Jack Vander Lucht, sorry, Jack, and then Karen Schellberg. The recording of this show will be available at nmu.edu/rural health. And another component that we've recently added is that we are putting quizzes with our episodes that we show. So this is an opportunity to assign that to students. And I just want to thank everybody and hope everybody has a safe Labor Day weekend. Thank you and good night.